What? In the waiting room, Anthony Lomer and Anthony Lomer's cardiac surgery. He's in the waiting room. Oh, he's letting them in.
Yes.
We're just going to give a couple of minutes before we get started today. So I want everyone to settle in. All right. Good evening, everyone. So welcome to the Grand Rounds. Today's presentation is going to be updates on coronary revascularization. And before we go into the talk per se, which will be followed by a panel presentation and discussion, this is the website where we have our Grand Rounds. So please feel free to go there and get yourself acquainted with some of the top-notch presentations that were made in the last 1 year or so. For the CME credit for the session, please text 12466 at 888-816-4893. And this SMS message can travel within 12 hours after the session, provided you have an active profile in Rutgers Class CME to acquire the CME credit. And also we provide the MOC credit, and the room code for today is Future 17, which means that there are 17 such sessions already existing, and you can visit them on the website. The one today is also going to be uploaded. And there's a link which is going to be made available to you in the chat box. You can see it here. And once you log in and answer a few questions correctly, you have an opportunity to get your credits and MOC points, provided your ABIM ID is existing, and it will populate directly on your ABIM website. Great. So with that, it's wonderful to have our presenter today, no other than Dr. Tudor Voginescu, whom everybody knows. But I always like to provide a brief highlight of the presenter's career. So Dr. Voginescu is Associate Professor of Medicine, and he did most of his education in Romania. And after the initial degree in MD degree and in medicine, he moved on and had his fellowship in cardiology. Actually, he did it from RWJ Medical School, Robert Wood Johnson Medical School, and subsequently a fellowship in interventional cardiology at Lenox Hill Hospital. He had his residency also within the same vicinity of RWJ at Nivak Beth Israel Medical Center. Dr. Voginescu is a leader and a force in the RWJ cardiac cath lab, where he is known for his wonderful skill sets, and also the fact that he's been as a top doctor in the interventional cardiology community in the Castle Connolly and the New Jersey list for the last several years speak volume to his popularity. His popularity is also well known in the clinics where his patients flock for him. So obviously he carries his clientele and has been wonderfully attached to the community here and has established his name and reputation. I'm sure his commitment is going to be sought for years to come. And today we're going to focus on his talk, which is going to center on some of the pivotal issues regarding revascularization. And we will be joining on the panel with Dr. Lee, Leonard Lee, Dr. Ramzan Zakir, and Dr. Ashok Chaudhry later on once he completes his presentation. With that note, Tudor, the scene is all yours.
Thank you, Dr. Sangupta, for very nice presentation, introduction.
There you go. I can see you.
Okay, can you see it now?
Yes, we are. Thank you.
Okay, so thank you again for this very kind introduction. And today we are going to talk about coronary revascularization. Question is, why do we discuss about revascularization in coronary artery disease? We want to see what does it work? The slideshow. Sorry about it. You have some small. Okay, so the timing and completeness of revascularization, the method of revascularization, and we have to have a look also about the registries versus trials in revascularization. So number one, why revascularization in CAD? And this is because if you have all kind of retrospective data, you see that at any point in time, having revascularization versus medical management shows an improved survival. And this is a retrospective data analysis from the Duke database, close to 20,000 patients followed over 18 years. And it is shown that these patients had at any point in time at 5 years, 10 years, as well as 15 years, a gradient between the medical treated arm and the revascularized arm. Over this long period of time where the follow-up was achieved, it's very important to understand the crossover. So patients went from PCI to PCI. Patient were crossed from PCI to PCI, from CABG to CABG in the lowest numbers, but they crossed over from CABG to PCI, from PCI to CABG, as well as from the medical arm to CABG and to PCI. So it's very important to understand that during a lifetime, a patient may go through different phases of revascularization, either percutaneous coronary intervention, open heart surgery, even if we choose to treat them initially medically. In the day and age of bare metal stent, this was reproduced in the Approach registry, which is a Canadian registry from Calgary and from Alberta and Ontario. And what was shown there is that in a 5 years follow-up, there is a gradient improvement in survival if the patient went to get PCI versus or CABG versus medical management. More recently, looking into the angiography of these patients over the last 10 years or so, it was shown that at any point in time, what was considered a more critical angiogram of these patients is associated with worse outcomes if these patients are treated medically. So again, it's registry data. You see a separation in curves in survival in terms of survival here and death and mild free survival. of events if the patient are treated with revascularization. It doesn't matter if it's CABG or PCI versus medical management over 10 years follow-up. And one can actually interfere here the percentages in which you have a event-free survival at 1 year. And you can say that the more aggressive you are in terms of revascularizing these patients, the better are they going to do. Regardless how you look into that, the most important thing is to define what revascularization means. And it can be anatomical, it can be functional, but the most important thing is if the revascularization is complete or incomplete. This was shown actually in a retrospective study by Hannan in the New York State Registry, and it was shown here you have 21,000 patients, out of which 15,000 have incomplete revascularization. This is a pooled data with CABG and PCI. And at any point in time, you see that if you have incomplete revascularization, there is a higher likelihood that these patients are going to have a higher mortality rate. And this is looking back at their angiograms, if you say it's 1 versus 2 versus 3 vessels of incomplete revascularization, the hazard ratio are higher for mortality if they don't get fully revascularized. Very interesting, this was shown to be the same in the ARTS trial. So here you see that if you have surgery, you have event-free survival in a significant better situation than if you get PCI. And if you do an incomplete PCI, so you have an incomplete revascularization by PCI, you have the highest event rate by 1 year. You don't pay the same penalty if you leave something not revascularized with surgery. A very important concept coming from the angiography trials was the residual syntax score. So see here, the syntax score calculated after revascularization in the patients who have low, intermediate, or high syntax score, and complete versus incomplete revascularization was plotted against the outcomes. And it's very interesting to see that once you have a higher rate of incomplete revascularization by syntax score, you have a higher event rate by 5 years follow-up. So this is a combination between the risk, the low baseline syntax score, higher incomplete revascularization, and this is the event rate, and it's going gradually up the higher the incomplete revascularization, the higher the event rate. The same thing was noticed also in open heart surgery. So close to 20% of patients may come out of the OR with incomplete revascularization. And in this case, the incomplete revascularization is an independent predictor of long-term mortality, as well as a significant independent predictor of hospital readmissions for cardiac reasons after initial discharge. You see that the most not revascularized vessel is the right coronary artery, followed by the circumflex, and the Lima to the LAD has the least amount of revascularization issues. This can be explained somehow to the fact that by leaving behind not revascularized myocardium, the bigger this myocardium is, the larger the amount of myocardium and the larger the amount of inducible ischemia, the higher the increase in cardiac frequency it is. And this was shown in a nuclear study in the early 2000s. Now, these are the latest guidelines of the professional societies, and they were reconvened a joint statement in August 2021. It came out early ahead of print in November 2021, and it was published in January 2022. And you see here that is a joint statement between ACC, AHA, and SCAI. So again, this is how the guidelines were drafted this time. And this is a slight change when you look in the last set of guidelines from 2014, because at that point in time, those guidelines were endorsed also by the American Association of Thoracic Surgeons, as well as by the Society of Thoracic Surgeons. So this doesn't have the stamp of cardiac surgeons when it was, published. This is in contradiction to the European guidelines on myocardial revascularization that came in 2018 out, were actually published in final form in 2019. And here the guidelines were jointly drafted by the European Society, by the European Association of Cardiothoracic Surgery, as well as by the European Association for Percutaneous Cardiovascular Interventions. If we look into subsets of patients that go through revascularization, these in the acute coronary syndrome basket, the trials over the last 10 years were extremely strong to support the concept of full revascularization in these patients. Now, it's very important to understand that it doesn't matter if you are dealing with a non-STEMI, a STEMI, or an acute coronary syndrome plus cardiogenic shock. The culprit vessel needs immediate revascularization. The null-culprit vessel can be done either immediate or deferred as per a flow reserve guided strategy. It is strongly suggested to avoid doing all vessels in a shock situation. Also, once the culprit vessel is done, if the patient has extensive coronary artery disease that mandates CABG, the CABG timing can be also discussed after the initial index event of revascularizing the culprit vessel. However, there is the trend that this cardiac surgery revascularization in acute coronary syndromes is not done right away. It's done within a couple of days after the index event. To that extent, the cardiovascular events associated with this procedure are going to be significantly lower than if the patient is going to done within the first 24 hours after the index procedure. In the non-STEMI acute coronary syndrome population, the clinical presentation will mandate the urgency in which these patients are handled. In terms of very high risk cases, you have hemodynamic instability or cardiogenic shock, mechanical complications of an MI. This immediate invasive strategy in less than 2 hours is mandated. The high-risk patients can be done in 24 hours, and an intermediate risk, they can be done within 72 hours. The group of patients with stable coronary artery disease reflects the largest amount of patients who come to our cath lab. And here you have multiple trials that were done over the last 10 years. And over the last 15 years, if you include courage here. And all these trials try to ask the main question, is medical management enough for these patients? Is revascularization a must? And if so, which of the revascularization techniques, PCI or CABG, is the best? At this point in time, after having the ischemia trial published, the most common approach to these patients with stable angina is initial medical treatment, optimizing medical management, treating risk factors. If the patient is still symptomatic, a CT coronary angiography has the role to identify the anatomy in a non-invasive manner. If there is no atherosclerosis, then lifestyle therapy as well as risk factor modification on top of the optimal medical therapy for functional angina is indicated. Limited non-obstructive disease requires additional moderate medical therapy. The moment when you have a failure of the medical therapy, you can discuss PCI or CABG. However, if you have left main or severe C-vessel CD and you have a patient who is diabetic, and or you have an ejection fraction of less than 35%, the patient should undergo coronary angiography, which followed by revascularization if indicated. This is what I will call an inconvenient slide. It shows exactly the major trials done over the last 15 years, the sites that were necessary to recruit, to screen and recruit the patients. You see the screened patients, you see the randomized patients, and you see the eligible patients here. And you see that at any point in time from Courage trial, for instance, only 6.4% of the screened patients were enrolled and randomized. In the last major trial, like the FFR guided PCI versus CABG phase 3, the number of patients screened is not even reported. However, in this trial, an extended enrollment was observed due to slower than expected enrollment rate. The ischemia trial had only 19.9, I mean, close to 20% of patients randomized. So these are the trials on which the guidelines were written. So not all comers were enrolled or they were eligible for the treatment that was recommended. To that extent, in a meta-analysis that has 25 randomized trials with close to 20,000 patients, the presence of revascularization on top of optimal medical therapy is associated with significant risk reduction in terms of cardiovascular events. This is obviously a meta-analysis, so it's not a randomized trial. Now, if you look into the algorithm in which decision-making is done, while in the basket of the acute coronary syndrome, the interventional cardiologist is alone in making this decision on the spot because they are acute patients. The moment when you have a stable coronary artery disease, it is required to discuss revascularization in frame of a heart team approach. And this is going to allow enough time from the diagnostic catheterization to decide the appropriate intervention. The guidelines are very specific about the revascularization, that they have to meet the clinical indication for the patient. It is always patient-centered, and it has to be extremely focused on an informed decision-making. So the patient has to have a full disclosure about the options that he has. And this has to include a heart team approach between the interventional cardiologist, the cardiac surgeon, and the general cardiologist, primary doctors who really know the patient, know the values of the patient, and know what the best strategy would be for the long-term outcome of the patient. And here, the United States guidelines published in 2022 are pretty much superposable with the guidelines from the European Society of Cardiology, where the heart team approach, the informed consent, as well as the protocols regarding these things are all considered a class 1 indication. Recommendations for revascularization to improve survival in this particular case in the new ACC/AHA guidelines give a level 1 only for patients who have left ventricular dysfunction and multivessel CAD, as well as to left main CAD. And in those cases, the open heart surgery is considered to be the avenue that is improving survival. Multivessel coronary artery disease, including stenosis in the proximal LAD, as well as single or double vessel not involving the proximal LAD, are all considered 2Bs here, and they go to the 3s in the final category. So technically, if you do not have left main, and if you do not have multivessel and left ventricular dysfunction, there is no 1A indication for any revascularization in terms of improving survival. And this is, I think, the main message that these guidelines have, in a contrast distinction we're going to see with the European guidelines. However, in patients who have stable ischemic heart disease with multivessel CAD that is appropriate for either CABG or PCI, the revascularization is reasonable to lower the risk of events such as spontaneous MI, unplanned urgent revascularization, or cardiac death. That is a class 2A. And in this group of optimal medical therapy applied to these patients, and patients are still symptomatic and they are amenable for revascularization, the indication is class 1. Now, in the European guidelines, you see that for both prognosis and symptoms, there are multiple scenarios: left main disease, proximal LAD disease, 2 or 3 vessel disease, large area of ischemia by functional testing, single remaining patent CAD. They are all class 1A for revascularization. So this is the difference here. And I think the difference is triggered by the ischemia trial that was published after the European guidelines were issued. The choice between the CABG and PCI in this particular situation is always triggered by the completeness of revascularization. So assessment of the STS score is considered a class 1 indication, and it is very important to understand the 30-day mortality as well as the in-hospital morbidity after the CABG. But if open heart surgery allows a full revascularization, that it's more comprehensive and more complete than PCI, this should be pursued first. And these are examples. What will favor PCI presence of severe comorbidity that is not adequately reflected in the scores. For instance, extensive liver disease doesn't get captured in the STS score. Advanced age, increased frailty index, reduced life expectancy, restricted mobility, as well as anatomical and technical aspects, low syntax score, chest radiation, adverse, chest, porcelain aorta. They will all tilt the table into PCI, what means a good CABG candidate. It's always a diabetic patient with reduced EF, contraindications to DAPT, recurrent diffuse instant restenosis, syntax score that's high, and sometimes if the patient needs concomitant interventions. Now, the largest meta-analysis looking into PCI versus CABG in the modern era was published in JAMA in 2014. And here you have studies going from ARTS to MASS to SOS, Cardia, and then Syntax and Freedom. And these were the only 2 that were done with the drug-eluting stents. The follow-up varies. It's anywhere between 1 and 6 years. And because of Syntax and Freedom, where the patients who were treated with drug-eluting stents had significantly more morbidity and mortality than CABG, the balance is tilted in favor of cardiac surgery. So mortality, cardiac surgery does better in the meta-analysis. Myocardial infarctions, same. Strokes, obviously with strokes, CABG does worse than PCI. In repeat revascularization according to the treatment arm, again, CABG does better. And in MACE, major adverse cardiovascular as well as cerebrovascular events, CABG does again better. So the meta-analysis supports CABG versus PCI in all categories of patient studies in these trials. Recommendations for patients with complex diseases. In patients who require revascularization for significant left main CID with high complexity CAD, CABG versus PCI is a class 1 indication in the ACC guidelines. If you have complex multivessel CAD with a syntax score more than 33, it is reasonable to choose CABG over PCI to confer survival advantage. Diabetics will always benefit from CABG. In the European guidelines, you see that in the they make a very clear separation: patients who have a low predicted surgical mortality, and these patients can go either with CABG or PCI. In one vessel CAD, 2 vessel CAD, left main CAD, 3 vessel with diabetes, and 3 vessel without diabetes at any point in time, except the only 1 vessel CAD without proximal LAD stenosis. CABG is a class 1A indication. Important subset of patients are patients who have ischemic cardiomyopathy. And in these particular patients, CABG may be considered to be done with adjunct procedures, plus minus temporary mechanical circulatory support. And at this point in time, these patients are better served in a major center that has also advanced heart failure therapy / heart transplant programs, because in the heart team evaluation, the heart failure specialist should be part of the preoperative workup of these patients. The referral in these heart failure centers is extremely important to assure the best treatment for this patient. Here you see that there is an algorithm in which these patients are actually worked up, and the question is, are they really indicated to get CABG? And what is the purpose of doing the CABG? Is it a final station, or is just an intermediary step towards the next step, like is the patient going to be reassessed after that at some point in time for other therapies? But if CABG is not an option, is the patient a candidate for LVAD, RVAD, and or heart transplant? And these are high-risk features of these patients. They are extremely sick, and that's why it's very important to have a heart failure specialist on them. These are predictors of poor heart failure survival, as well as anatomic risk that these patients may encounter. So again, if someone has this kind of patients, referring to a center with heart failure, advanced heart failure, heart transplant is the best in terms of establishing the best care for them. Procedural aspects are treated in this guideline, in the new guidelines. So in case of CABG, besides using the Lima as a standard conduit for the LAD, there is the recommendation that using arterial grafts, so radial artery versus veins, is highly recommended. Also, if bilateral mammary arteries can be grafted, that would be ideal. It would be beneficial in appropriate patients to improve long-term cardiac outcomes. Also, the off-pump technologies are recommended to decrease the perioperative stroke if patients have significant calcification of the aorta or significant pulmonary disease. And the same is paralleled into the European guidelines. You have it here in a more descriptive way: Lima to the LAD, radial grafts, epicardial echo during the OR to facilitate the graft insertion, endoscopic vein harvesting, no-touch vein harvesting, and off-pump surgery if calcified aorta or high risk. From a percutaneous intervention point of view, procedural aspect pertain the access. Radial is considered a class 1A indication in both guidelines, and drug-eluting stents are the only stents that were recommended. They are recommended over BMS for any of the PCIs, irrespective of the clinical scenario in which the patient presents. Use of coronary physiology is a class 1, both into the European as well as in the US guidelines. Intravascular imaging in order to improve stenting as well as to assess left main is a class 2A indication in both set of guidelines. If you look into procedural aspects, in the European guidelines, the CTOs are getting a 2A, while in the US guidelines, they are 2B. Also, hemodynamic support, it's a 2B. The debulking is also recommended with 2As and 2Bs, depends on the equipment used. Most important is that when we speak revascularization, we have also what we'll call myocardial revascularization failure. And these are due to PCI failure, such as stent thrombosis, as well as in-stent restenosis, CABG failure, early and late graft closure, as well as CAD progression. So the stent thrombosis can be early, late, or very late. And the Stent thrombosis has risk factors that are patient-related, lesion-related, or stent-related. Underlying mechanisms are multiple, and they can be always identified by using intravascular imaging. The same thing pertains to in-stent restenosis, but here the patient-related factors such as diabetes, as well as prior bypass surgery are very, very important. See here examples of mechanisms for the stent thrombosis, such as underexpansion, loss of stent integrity, malapposition, neointimal hyperplasia, or neoatherosclerosis. And this can be assessed with intravascular imaging, OCT, or intravascular ultrasound. Then the lesion needs to be prepared again, and then sometimes you can put a new stent in, but the recommendation would be to repeat stenting in case of optimal results after lesion preparation, because these stents already closed one time in an acute manner. You don't want to close second time with more stents in. In terms of intravascular in-stent restenosis, intravascular imaging is again very important to elucidate the mechanism and to choose the right method to treat this kind of pathology. With regard to the surgical graft failure, if the patient is hemodynamically stable, percutaneous intervention is the avenue to go. And the question is, are you going to treat the native lesion preferentially versus the CABG, the graft? That would be the preferred avenue. If the patient is, stable and there is enough time to reassess the reason of the graft failure, patient can either be treated medically, or if there are errors or some surgical failures, then the patient may be considered in rare cases for redo CABG. Whenever you consider revascularization for CAD progression, it's important to look into the surgical risk scores, the complexity of the coronary artery disease, and the experience in surgical or percutaneous revascularization of the center where these cases are done, and patient related factors such as patient preference, as well as his willingness to take or not to take dual antiplatelet therapies. Again, these failures can be easier addressed by doing prevention of these failures in various clinical subsets. In stent thrombosis, for instance, most important thing would be to ensure depth compliance. In-stent restenosis, to use liberal intracoronary imaging during the index event. For the graft failure, to use the right CABG techniques and to see the suitable patients. And for progression of CAD, treatment of risk factors is paramount. Summary: myocardial revascularization is performed today for the relief of symptoms of myocardial ischemia and the improvement of prognosis. In stable coronary artery disease, the prognostic benefit is dependent on the extent of myocardium subject to ischemia. The prognostic as well as symptomatic benefits of myocardial revascularization depend on the completeness of revascularization. Therefore, the ability to achieve complete revascularization is the key issue when choosing the appropriate treatment strategy. Apart from issues on individual operative risk and technical feasibility, diabetes, as well as the anatomical complexity of coronary artery disease, determine the relative benefits of PCI and CABG. It is very important to see that in the current guidelines, the goal of improving patient outcomes, it is recommended that both cardiac surgery and PCI programs will participate in state, regional, or national clinical data registries and receive periodic reports of their risk-adjusted outcomes as a quality assessment and improvement strategy. So these activities that we do are all monitored for outcomes, to give feedback and to expect better outcomes from one trimester to the other, or from 1 year to the other. In conclusion, The revascularization per se should always be additive to risk factor modification and medical management. Surgery and coronary angioplasty are always complementary and not competitive or exclusive revascularization methods, and they treat the same disease, which is coronary atherosclerosis, at a different stage. The timing and best choice of complete coronary revascularization is always a team approach involving the primary cardiologist, the interventional cardiologist, and the cardiac surgeon. And the patient needs to be made aware of the importance of the medical management and the long-term consequences of the revascularization method. Thank you.
Thank you very much for giving a fairly exhaustive overview in a very short period of time, I would say, Tudor. So let's bring our panel. Ashok is here, Ramzan, Dr. Ramzan Zakir is here. And I wonder whether our surgical colleague, Dr. Leonard Lee, has joined us. Let's wait and see if we can find him. If not, let's start asking. I think, Tudor, you really nailed the final summary slides, which is very important, of prevention, and then secondly, using all the guideline directed therapies. Now, based upon your survey of what we did there, can you summarize what are the opportunities you feel are currently there at our place? Where do you think we do well? What are the places where we should be focusing on as we move into the new environment? So I'm going to start with you, Tudor. What are your impressions about what are the opportunities? How much of it we are following? I'm really interested to see where do you think we stand and what is the opportunity for us?
I mean, we do have here a very close collaboration with our colleagues from cardiac surgery. We do consult with them on a 24/7 basis for all sick patients. I think the next step would formalize that in a way that we are part of a larger system, that this becomes a standard practice across all hospitals in the system. And definitely will keep in the loop the referring physician. I would love to have at any point in time more input from the referring cardiologist regarding the values that the patient has, as well as what the patient really desires and what the family expects. When you meet these patients in a very short time frame, and you have to make a decision about their whole life, it's extremely complex. So you do a STEMI, that's okay. But then after that, if the patient deteriorates, are you going to take him back to the lab? Are you going to put extra devices, hemodynamic support? Are you going to call your surgical colleagues to do full revascularization? And you don't know what the patient expects. So I think having these discussions would be extremely beneficial in terms of defining goal of care for at least one group of very vulnerable patients. Having this kind of conversation on daily basis, I think it's extremely important to establish them as a standard on which we practice.
So let me ask for a difference. So I think it's a very complex. Let's assume we're talking about more about stable coronary artery disease or patients typically of large ischemia, burden on and you have got coronary artery disease established, and now you're trying to do a PCI versus CABG discussion. And now this patient has been referred from outside, and you are here. We talk about this heart team discussion. What should that be, heart team discussion? And you mentioned a very nice point that we should include the referral physician's input into consideration and do a heart team discussion. Does that really happen? Or is it in tandem? Or how do you really materialize it? I mean, maybe I'll start with Ashok. How do you do this? I mean, because it's very complex setup. You're in the cath lab, you're the operator, the referring physician is somewhere else, the family is outside, the patient may be on the table, or maybe you have spoken to him, and the surgical team is somewhere else. How does that happen? What is the heart team? How do you make it all so synchronous? What do you think?
So I think it's a very important piece of clinical decision making that a lot of us have to remember and try our best to do. So the example that you bring, where a patient with a very large ischemic burden, but at the same time they have a stable CAD, it's a very controversial patient. You know, if you look at a lot of the recent trials, the biggest one being ischemia trial. Of course, there are limitations of all those studies with enrollment and whatnot. But the bottom line is, if you have to be on maximal tolerated medical therapy, you have to be symptomatic, and at the end of the day, you're not improving their survival, but at the most you're improving their quality of life. So the problem becomes, if you get a referral from a community cardiologist for a patient for a PCI, they'll just say, okay, we have a patient who came with some chest discomfort. I did a stress test, it is positive, I'm sending you for a PCI. So there is a level of expectation on the part of the family that they will get a stent. There's a level of expectation from the physician that they will get a stent. And then when you're seeing the patient, you notice that, well, they're only on a low dose of beta blocker. They have not been tried in maximum medical therapy. And then it becomes tricky. So I think there is a role for improvement from a society level, from a system level. But from a personal perspective, I think you reassess the patient, and then you become honest with the patient and discuss them, saying, listen, you know, when we put stents in you, we're not improving survival, we're trying to improve your quality of life. And then we go into the discussion of the symptoms that they have, the medications that can be improved upon, and then focus on the completeness of revascularization. Review the coronary angiogram, look at the complexity of the data, you know, what their left main lesion is a multi-vessel CAD. And when you say heart team, you know, if it is a straightforward, simple lesion on someone who is very symptomatic, then you review with the primary cardiologist who's referring you. However, if it is someone who has a severe LV dysfunction, EF of 25%, you have 3-vessel CAD, prox-LAD, and you know, multiple studies, whether it's Freedom, whether it is FAME3, all of them pointing to the fact that, you know, maybe surgery is a better option, then it becomes tricky, because, you know, I think they are sending you for a PCI, and at the same time, you have to do what is best for the patient. So sometimes you just take a pause, call the physician and say, hey, listen, you know, I know this patient we are getting for a stenting, but I think we should just take a pause, involve a surgeon, and then discuss. And maybe at the end of the day, he may not be a surgical candidate, or maybe at the end of the day, the person may refuse. But I think with the most recent data we have, it's our obligation to kind of understand that and present in a more collegial fashion. And I think, you know, from a surgical perspective, I think some of the issues which we need to discuss is the completeness of revascularization with arterial grafts. Are we doing more radial grafts here? Are we doing bilateral Lima grafts here? So all of those discussion, I think, has become important from a heart team approach.
Yeah, so I think you know where I'm going with this, right? So I'm going to come to Ramzan. So Ramzan, what's your trick? So you put the gun on the patient's head and say, you got a 3-vessel disease. I'm just joking. I mean to say that it's a very pressure situation, right? So the patient is on the table, just got the coronary anatomy in front of you. Maybe the patient got a little bit of sedation and is in expectant mode. The patient's relatives are outside. And then you have to, in this environment, on this referred patient who's on the table, we have to make a decision of how do we proceed with revascularization. Or do you decide we're going to just bring the patient out and discuss? I see that also happening sometimes, right? We do see, you know, it's a 3-vessel disease, it's not clear. Let's bring the patient out. But then, you know, there's a question about, did we miss the opportunity to get it all done in an efficient fashion? So Ramzan, what's your trick? How do you proceed?
Yeah, I mean, I think the key word we're mentioning is stable coronary artery disease, right? So there's no urgency in revascularizing that you feel obligated that you have to put a stent somewhere just because you put the patient on the table. So, you know, our goal is to improve symptoms and long-term outcomes, but you know, so there is absolutely no rush, and there's no, you know, you don't have to feel bad that you didn't intervene right away. So when you have a patient with multi-vessel disease, especially if they're diabetic, you know, you got to quickly, you know, calculate a Syntax score. And if all those things are leading towards that CABG, you know, may be a better option for the patient, I mean, I don't think you feel any obligation to a referring physician that's referring for a PCI. You just got to do what you know is best for the patient, and a discussion, have them review the cases, involve the patients. Ultimately they have to make a decision as well. A lot of times they base it on how you kind of steer them, but they also have their preferences. Some of them do their own research, and they involve some of their family members who may be physicians as well into the decision making. But I think the key thing is that it's stable disease, and that you should not feel obligated to put a stent on somebody in that situation. You feel surgery may be a viable option. So I mean, I think really having a detailed conversation with surgery with the patient is the best step, and don't feel rushed or pressured to do a PCI just because you can.
So I think it's a very important point, and I just wanted to just reiterate that, because I think we do have some variants sometimes we encounter. And I think as people are listening to this, and as our trainees are listening to this, that the oculostenotic reflex should not be operating over your abilities to make the right judgments for the patient. And it's very difficult to entrain the patient's interest in mind, because when having a conversation when the patient's on the table, it's very difficult. So I have seen that in the past. So I just wanted to highlight that. So thank you for that. Now, second question that I would now want to bring back to Tudor is, now in ischemia, there's like CT coronary angiogram is taken precedence, and I think we are not doing that at least in RWJ environment as much of CT coronary angiogram, and that's an area for further growth. But perhaps having the CT anatomy up front may allow us to make more improved decision. What do you think, Tudor?
Well, I think these are recommendations. In real life, we deal more with positive stress tests when they come to the lab. Being a major referral center, we get patients who have already diagnostic coronary angiography done. The CT as a concept, it's good because you screen patients. It's a non-invasive manner, and lots of the patients love to have non-invasive tests. The question is, do you believe the patient or do you believe the CT, because the patient is symptomatic? So I think the value of the history, it's somehow washed out in all these trials, because if the patient gives you a very good history, even if the CT is not that clear cut with triple vessel, you can take pictures, and we have situations where the CT was unremarkable and patient had severe disease as well as the opposite. So the CT was red left main disease. We took pictures and all the calcium was in the wall. So the coronaries were fine and the patient didn't need any intervention. So I think you have to listen to the patient first. Having the CT as a additional information, and I think that now you have the CT as well as the non-invasive FFR that will give you far more information than the CT alone, would be extremely meaningful when you assess these patients before discussing further options.
Okay, so I think, and those are important points. So where are we going with FFR? I just wanted to bring that controversy out. I mean, we are getting some mixed messages. Ashok.
I think you have to. Here to stay. We have a few more studies coming out. It's not going to go anywhere. But I would say in terms of completeness of revascularization in deciding intermediate lesions, and I think it'll definitely help you in some ways. For example, let's say you are faced with someone with multivessel CAD, and then you're deciding on the concept of surgery versus multivessel PCI, and then you have a LED lesion, you have a circumflex lesion. It looks 70%, 60%. You throw in FFR wire, and your value is 0.88. At least based on earlier studies, you know that at the end of several years, their outcomes is going to be similar to medical management. So you save a stent, patient is not harmed, and you did the right choice. Now, I think the controversy came with regards to the recent study, the FAME3 study, where you are comparing two different strategies. You are comparing PCI versus CABG strategy with regards to FFR guided strategy, and there was the surgery came on top. But I don't think it's an issue of FFR. I think the issue of strategy in the setting of multi-vessel CAD, or in the setting of, for that matter, in other studies, diabetes, it's the choice, different strategy. I don't think there's anything wrong with FFR. Again, there will be people who'll say, well, why do I need to do an FFR if it's not going to make a huge difference? But I think in a lot of situations in everyday life, we make decisions based on FFR. I think physiology is very important. We need to understand that, because at the end of the day, we are looking at symptom relief, angina relief, and we also have to remember that the study that we were quoting is not a adequately powered study. It is not a study that was looking at they were looking at non-inferiority indices, right? So we have to look at the limitations of the study as well. So there are multiple things in that study we have to look at before we say FFR is bad. I think it's there to stay. There's more studies coming out, and I would encourage everyone, especially the trainees and everyone, that when you have a choice, you should do more imaging, you should do more physiology.
Great. So for now, we will continue to practice until more data is thrown in terms of FFR and its value. I think for FFR, you will continue to use the physiology of it to making recommendations. Now, another question that comes up, and this is a little bit more concerning, particularly in female population. We are seeing this emergence of what is called as INOCA, or ischemia with non-obstructive coronary artery disease, which becomes a very difficult population to treat. And you get non-obstructive disease, a macrovascular disease, and typically either we are ignoring that, or we do not have good understanding about it, at least in clinical practice. However, we know that these are frequent comers, and these patients often come back. Sometimes they come back with also not only just ischemic symptoms, but also we have seen that MINOCA and INOCAs, and these are the new blurry margins of coronary artery disease. How much of that is a problem with obstructive coronary artery disease concomitantly?
Well, I mean, we are on the learning curve. MINOCA as a concept grew dramatically over the last decade. We see it under the form of spontaneous coronary dissection on one end, and the guidelines are very specific that this is a 2B2 instrument. They need to be instrumented only if the patient is in critical condition, like in hemodynamic compromise or severe arrhythmia, ischemia-induced arrhythmia. And obviously we had cases like that, and we use liberal intravascular ultrasound just to make sure we don't go into the false lumen. The other patients who have normal coronaries and have microvascular disease, they may benefit from additional testing as well as risk factor modification. I think this would be the category of patients where you take a very, very elaborate history, and then if they have at any point in time a coronary angiography and you know the anatomy, and if they come again and again and again, then the CT scan would be a major advantage, because you save them an invasive procedure again.
Yeah, and just in the terms of, I was talking about INOCA, means ischemia with non-obstructive coronary artery disease. It's not uncommon. I wanted to make sure that people will recognize that if you have a non-obstructive coronary artery disease, mild atherosclerotic plaques, and some of these people can have ischemic burden, and those are not false positives. So I just wanted to make sure that people recognize that these are people who still need to be treated. It's not a false positive stress test. So sometimes we do get this challenge in understanding this anatomy. Oh, that stress test was falsely read or something like that. That's not the case. Maybe many times you need to just review the data clearly, and the history will be very typical. So, you have to go back and forth and treat those patients. So that was the message. There was a question in the chat box. When would you do an imaging study after revascularization? Now, if I understand the guide, if I remember the guidelines correctly, there is no need for a routine imaging if a patient is asymptomatic or no change of symptoms. And typically, before 3 years, no routine nuclear stress testing after revascularization would be of necessity unless the patient changes the status of the disease, of there's some kind of a changes seen. Is that also the your consideration? I mean, that's what I learned, if I remember some time back. Is there any change in the guidelines?
No. I mean, the guidelines don't specify this particular set of guidelines. I think that's going to come in a non-invasive guidelines, stress test guidelines. But in my personal practice, I never do stress test if the patient is totally asymptomatic. Truth be told, I encourage my patients to exercise as much as possible, between 30 and 60 minutes every day, 7 days a week. We have this discussion each time they see me in the office. I ask them specifically, how much do you exercise? What is the highest level of exercise that you do? What are your symptoms? And if he starts developing symptoms, that's a different ballgame. But if the patient is asymptomatic, we don't stress them. Even if we do a CTO, even if we do multi-vessel PCI, even if they have multiple stents. And we have follow-up more than 10 years with patients. If they are very, very strict with healthy lifestyle changes, they stick to lipid control, they take their statins, they don't gain weight, they exercise daily, they are all fine.
Yeah. And one thing I wanted to point out, and I've seen this sometimes, I mean, this is my preference and maybe variance in variance. So if I have a patient who was revascularized and is on guideline-directed therapies, and if I'm suspecting, or if I even want to do a stress test, don't discontinue anti-anginas. I actually don't stop my beta blocker. I let them go through the stress test with the full medication, because if they're not ischemic, I'm not going to do anything. That means they're completely protected even after their extreme stress test. But I've seen that often people discontinue the beta blocker, discontinue the medication, or have a concern, oh, we didn't reach the target heart. Who cares? The patient was asymptomatic, didn't do anything, there was no ischemia, and the patient exercised through for 9 minutes, 10 minutes, and there was everything. But I mean, that was something I've seen that, but there's a variance there also. We see, maybe we'll need to discuss that at some point in time, but I think we shouldn't go into the non-invasive category. We are in, let's talk a little bit about CTOs, and Ramzan, that's your area of interest. So what's the latest on the CTOs in terms of,
well,
yeah,
it was a little bit of a disappointment the way the guidelines handled CTO revascularization. They based it on the Decision CTO study, and there are a lot of issues with it. Tudor brought up how you screen a lot of patients, and then ultimately what you wind up doing in these interventional trials is sub-selecting the lower risk group of patients. This is a problem that we face in interventional cardiology. Is what comes with these patients is there becomes ethical issues that we face, is that patients who really need a PCI are not the ones that get randomized in the study. And ultimately what they do is you wind up sub-selecting a lower risk group of patients. And then there's a lot of crossover. So in Decision CTO, immediately there's a 20% crossover. And then you just look at your intention to treat analysis. And then we wind up with these conclusions that always make intervention kind of look, a little bit questionable. And you would think that the guideline committee would, look at Decision CTO and look at all the flaws in it, and recognize that, but they jumped all over it. They really, took a blow on CTO revascularization and the new guidelines. If you look at a lot of the others, I mean, we know patients with large ischemic burden that are largely symptomatic are going to benefit from CTO revascularization. So, I mean, I think, in order for us to really, conduct studies that show benefit in interventions, it becomes a problem with these patients that are extremely symptomatic. And how do you enroll these patients to medical, they get randomized to medical treatment, and how do you keep them how do they stay in the medical treatment arm if they're markedly symptomatic?
Yeah,
so from a guideline standpoint, it was a little bit discouraging to see. I don't know about Tudor. What are your thoughts on that?
Yeah.
Well, I mean, you have this discrepancy between the European guidelines, where CTOs are still a class 2A, and the US guidelines, where you have them labeled as 2B. I think the avenue of pursuing is that doing PCI for symptom improvement, it's a 2A. And if the patient is symptomatic under medical management, doing intervention on these patients, it's absolutely justified. It's a class 2A indication. Now, what I want to say, I always fall back on a very old registry that comes from Mid-America. There's close to 1,600 patients followed over 10 years. It was published in 96 in JACC. And the only thing that we learned from that trial, which was a single center retrospective analysis, is that the larger the amount of myocardium that is salvaged, the higher the gradient in survival. So a PCI to a LAD as a CTO LAD will carry a far higher benefit in survival than if you do a PCI to a CTO of the obtuse marginal or diagonal. So you have to be very, very cognizant about the amount of myocardium that you are going to intervene by salvage the moment when you intervene on these vessels. So we always have a very long discussion with the patient, and is the long-term aspect of it, like there are multiple stents, overlap stents, risk of restenosis, long-term dual antiplatelet therapy. But these are the patients where you have the largest time to speak about revascularization, to send them to surgery, to bring them back. So this is where the informed consent, in my personal opinion, is the most important in the chronic total occlusion population. And I think the trials are there, and this 2B may become 2A next time when the guidelines are going to be rewritten.
Yeah, and I think I mean when it comes to CTO, I use two as you correctly pointed out. I mean, what's the area? How much is the myocardium at risk? Number one. Number two, is there LV dysfunction? It becomes easier if there's LV dysfunction. I mean, you're going to have a benefit in one form or the other. In general, any of those, two vessel disease, three vessel disease, LV dysfunction, it's much easier. It's become a little bit more complicated when you have a normal LV function. Then, of course, you have to look into which vessel and how much is the ischemia.
And just how symptomatic these patients are, despite medical treatment, because quality of life is important. Some of these patients can hardly take, walk a half a block, and they have to stop during chest pain. It really limits their quality of life. It has effect on their, leads to depression, leads to other issues as well. So I think, a lot of times, we don't pay enough value towards quality of life. We look at harder outpoints, which is important, but quality of life, to our patients, it does mean a lot.
Yes,
I think, yeah.
Yeah, go ahead, Ashok.
No, I think I was just adding on to Ramjan's thing that even in not only the CTO, but I think in the setting of all stable CAD, the only thing that we keep on coming back again and again and again is not mortality benefit, but the quality of life and symptom relief with intervention. So I think, you have to be very symptomatic, large area of ischemia on maximum medical therapy. And if you can offer an intervention to relieve their symptoms, then that's the most we can do at this time. Of course, we'll have more data hopefully in the future.
But if you have LV dysfunction, or even if you have LV dysfunction on stress test, then you have mortality benefit.
That's correct.
So if you have an LV ejection fraction is low, then you don't have much problem. The other one is more discussion comes into play, but you're clearly going to have a mortality benefit if you have LV dysfunction. But I think we should also not ignore the impact of all the preventive therapies and exercise treatment, and I mean that's important, and behavioral aspects of in a medicine, which is very difficult to engage on in a short period of time when you're in the cath lab, but do have a long-term implication on this patients having an Hawthorne effect on continuous monitoring in some way or the other, so that they're able to follow, which is the most difficult portion. It's easy to revascularize, but it's very difficult to make them compliant and have the behavior modification. But that may be the more important aspect of their long-term benefit. But gentlemen, thank you very much. This has been a wonderful discussion. And if there is no other comments, any other comments from anyone? If not,
I just want to one last comment that regarding FAME 3 and there was only 12% use of intravascular imaging. And I just want to highlight, from, the IVUS XPL and the ultimate study showing, significant 40% reductions in MACE with imaging. And I think moving forward, it really should be used for almost all our PCIs. We're having more, data to support that it leads to better outcomes. And, just by sizing vessels just by the eye and not, imaging and stuff like that, I think we're kind of doing a, injustice and stuff. So, I mean, I think definitely, I think we can improve outcomes and get a lot of these results more favorable with widespread use of imaging.
Do we do OCT here? I didn't know.
Yes.
Yes.
Yeah, we do.
We have.
Great.
Yes. Yeah.
So yeah, I like intravascular imaging is very good. Yep. Very good. Thank you very much. We look forward to continued update and all the good work that you all do in the cath lab. Thank you very much.
Thank you.